Thank you very much for attending. It's 2 minutes past 10, and inshallah we would like to start on time, and hopefully I know the ladies would like to be home after Dhuhr, so we have the eye on the clock all the time, inshallah. I want to just extend to you a very warm welcome. There will be a formal welcome a little later on, but for now, if I can impose upon our Dr. Saab, Dr. Yusuf Patel, to offer us a short opening dua, inshallah.
بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا ونبينا ومولانا محمد وعلى آله وأصحابه أجمعين. ربنا آتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار. ربنا تقبل منا إنك أنت السميع العليم وتب علينا مولانا إنك أنت التواب الرحيم. سبحان ربك رب العزة عما يصفون وسلام على المرسلين والحمد لله رب العالمين.
Shukran very much, Dr. Saab. The next item on the agenda is the official welcome on behalf of the Masjid Committee and the Imamate, and it's my great pleasure and honor to welcome the chairperson of the Executive Committee, Muhammad Abdullah, to do so. Muhammad.
Shukran Satarbai. Assalamu alaikum wa rahmatullahi wa barakatuh. I think it's a very important topic that we are providing a workshop for today. We'd like to just introduce our speakers. Dr. Faima Parker, geriatrician at Vincent Pallotti, Dr. Yusuf Parker, is also Islamic spiritual counselor. Patel, sorry. Yusuf Patel. Too many Parkers around. And Professor Hussein Ibrahim from the University of Minnesota. He's a psychologist. Dr. Ibrahim does a lot of work with us at the masjid in terms of counseling, pro bono basis. So he's got a lot of experience as well with family issues, as well as dementia is also a topic. Just a reminder for you that there's a parenting workshop also on the 22nd of March, Saturday 22nd, between 10 and 12, which Professor Ibrahim will be running with. So inshallah, if you're interested, please join that one as well. It's going to be a very interesting discussion, and keep your questions. There will be a question and answer session at the end. So inshallah, keep that for later, and please enjoy. Shukran. Assalamu alaikum.
Okay, thanks, Mohammed. All right, so the first question is, what's the purpose of having an event of this nature? The purpose basically is, if I can go back, in Ramadan, the masjid has a number of different types of events, both spiritual and non-spiritual. We have taken our cue from the very famous Dr. Abdullah Hakim Quick. Many of you are familiar with him. He's a very great and motivational speaker. And one of the Jummah talks he gave, and I remember this very well, he said, Ramadan is not a month of hibernation, it's a month of hyperactivity. So we like to do that, and we've found over the years that the seminars are, alhamdulillah, as you can see here, well attended. I think the men are still sleeping, but that's fine, another story for another day. And among the very popular seminars we had many years ago was the one on organ donation. Don't know if anybody was here, very popular one. Last year we had the one on inheritance for ladies. That was also a very popular one. So the reason we have selected this topic today is simply because the closest thing that you have to yourself today, unfortunately, and I say this with great regret, is no longer the family, it's the phone. And every time, every morning you open up your phone, it's just bad news. Somebody's passed on, Allah grant him all a very high place, inshallah. And of course, people who are inflicted with many types of medical conditions. Among them, of course, nowadays, which seems to be very prominent, is the condition of dementia, Parkinsons, and Alzheimer. And that's why, because many families are faced with this type of trauma in their homes, we thought that we would invite a very prolific and a very highly qualified team with us here today, and they are here today, and they've been introduced. Please give them a very warm round of applause. So the idea is today twofold. One is to be able to know a bit more about the condition, and secondly, to be able to, once we are empowered, to be able to give support to those people. those are the two objectives that we have in mind here today. So our first speaker is Dr. Fahima Parker. She studied a degree in medicine at Stellenbosch University, furthered her journey in medicine at UCT and at Groote Hospital, a physician, a specialist, and I must get this word right, it's geriatrics. Is that right, Doc? Yeah. Okay, all right, I think I've got it more or less right. And to sum it all up, she has a huge passion, and my family can speak about it, and I'm sure many families here can attest to it, for the care of elderly patients. Please put your hands together for Dr. Fahima Parker.
Just go to the top. Yeah, that's perfect. Where is the pointer? Assalamu alaikum, everybody. Shukran to the Quds team for inviting me to speak. I know the topic also said Parkinson's disease, but I think dementia is already a bit overwhelming, and so hopefully by the end of today you'll have a better understanding of what a dementia is and how to help yourself or a family member, inshallah. So so I think for us, we all worry as we get older that, you know, we're becoming forgetful, and so I just think it's important for everybody to know that because you are forgetting, it doesn't mean you have dementia. Okay, so just not every memory problem you have means you're developing dementia. So we have been created so beautifully, so amazingly. Our brain is like this powerhouse that holds information. It's a processing unit, it's a computer that we have that learns information, it stores information, and with all that information that we have, it helps us manage ourselves in daily functions to be able to fry an egg, take out the dirt. So it happens so instantly. All these inputs and things we get in, within milliseconds, our body is just acting, and we don't even have to think about any of that. So our brain is involved in many functions that allow us to live safely, independently. And so as we do get older, we can become forgetful. And we look at memory impairment. So think of memory as information and function of the brain. We look at memory impairment as, is this normal for somebody who's getting older? Does there seem to be a mild impairment? Does this patient actually have a dementia? Okay, and so there's a spectrum of illness, and some people may never develop dementia. They may have mild cognitive impairment, and what that is maybe being forgetful, but they're actually coping and they're managing, and it's not affecting their normal daily functioning. But when that starts to impact your normal daily function, that's when we start to worry that this may be a progressive disorder. So as we get older, we all will remember immediately. If I give you somebody's phone number and I say, Shanaz, repeat it now, she will be able to, Sharifa, sorry, not Shanaz. So I remember. That's my working memory. That's my short-term memory that's working. So we'll all be able, as we get older, if somebody says, repeat this number, 1, 2, 3, you'll be able to do that. Our short-term memory, which is our working memory, it's our random access memory of our computer, and our long-term memory does tend to decline. But it doesn't affect our functioning. And so, yes, we may forget something, but if somebody says, don't you remember when you were 12 and mommy caught you drinking the Faluda, and you go like, oh, and you remember that whole day and how you got punished. So, you know, it's still there, and a simple cue will bring all that information back to you. So yes, we will have some changes. We will also take longer to learn things. We will be slower in learning things, but we will continue to learn things. And so it's important to know that as we get older, we are slower to learn new things, but we are still able to retain information, and this does not impact on our function. So what is a dementia? Everybody says, okay, so I don't have Alzheimer's, but I have dementia. So dementia really is it's not a specific disease. It's a global term we use for symptoms that affect memory. So basically that affect normal function of the brain. It's a term we use to describe that, and there's different disorders that affect brain function. So when these symptoms of memory impairment start to impact on your daily functioning, not remembering to bath, I know that sounds a bit more drastic, but you know, being able to live safely, independently, cooking, organizing the shopping, when those things start to impact, when you lose your normal functions of your brain, and you cannot live safely, independently, that's when it becomes a dementia. So I like to explain to the families, just like you get heart failure, you get kidney failure, you get lung failure, you get brain failure. That's what it is. It's a chronic condition of the brain, and you slowly start to lose function. So just to clarify, dementia is the global term, it's the umbrella term, but Alzheimer's is a type of dementia. Okay, so like you have different cats, you can get a Siamese, you can get a tomcat, you can get, what's the other one? Persian cat, we actually have one. Alzheimer's is a type of dementia, so that's how you need to understand it. It is the most common of all the dementias that we see. Of the majority of the patients that are diagnosed with cognitive impairments, dementia ranges between 60 to 80% of those. Following that, we see vascular dementias, and these are people who've had multiple strokes in their brain, patients who've had a condition called cerebral amyloid angiopathy, where there's bleeding in the brain. And sometimes we actually see both pathologies, patients who actually have a combination of both Alzheimer's and vascular pattern of testing, and that's what we call mixed dementias. So these are the most common dementias, Alzheimer's, vascular, and mixed. And then we get the dementias that does happen eventually when patients develop Parkinson's disease. They can develop dementia, and frontotemporal and Lewy body dementias. These are the rarer ones. We see them more in younger patients. For the purpose of this talk and the timing, I'm not going to go into all the specific dementias, and I'm just hoping to give you an overview and an understanding. So I think what you want to know is, am I at risk for having dementia? Okay, so there are certain factors that we cannot change. They're called non-modifiable risk factors, and we may have them. And there's modifiable risk factors. And you will see the modifiable risk factors by far are more than the non-modifiable ones. So low level of education. So the younger patients, the older patients who've had to leave school at the age of 3, our families now that are young families in schools, gosh, we have an education crisis in our country. Education is a very important factor in developing dementia. The lower your level of education, the higher your chance that you would develop a dementia. Age is by furthest the strongest factor for developing dementia, irrespective if you have a genetic component. After the age of 65, when things start to go wrong and you start becoming forgetful, and it's most likely that you probably have a mixed dementia or Alzheimer's. So there are certain dementias, Alzheimer's and frontotemporal dementia, that have a genetic component to that. And if you have a family member with one of these dementias, there is a risk that you may develop it. So Alzheimer's dementia, there are two types. We get the early onset, and these are really in patients younger than the age of 65. I have a few patients who in their 40s already started developing cognitive impairment. There's a very strong genetic component. You do have to, there's specific genes involved. I'm not going to get into that, but they can do testing for it. Later onset dementia was normally called sporadic dementia, and it's really after the age of 65 when things start to change. When we start to pick up the impairment, there is a genetic component there. There is a gene as well, but it doesn't necessarily mean that your risk, again, for developing the dementia will happen. Very importantly, with late onset dementia, and should you carry the ApoE gene, if you have uncontrolled chronic metabolic factors, your risk then definitely increases for developing Alzheimer's. So chronic metabolic conditions are a very important risk factor, a very important modifiable risk factor that we do need to, and I think it's very important to mention, that we can control. Hypertension, diabetes, obesity, and elevated cholesterol, yes, people who don't want to take their statins, that increases your risk for developing dementia in your midlife. So very important. Cardiac disease, patients suffering from heart failure, abnormal heart rhythms, previous heart attacks, previous strokes, also increases your risk for developing dementia. And then importantly, lifestyle. Fortunately, alhamdulillah, we do not drink, and we have been blessed with that information. We were far beyond our times. But smoking, a lot of our community smokes. They don't seem to think that it's something that's actually harmful, but it is, and incrementally it will become so. Physical inactivity, yes, not our culture to exercise, but kudos to Mr. Parker and his wife every Sunday morning on the promenade. I see them. Well done. I am impressed. And then social isolation. Being withdrawn, not wanting to engage with people, also increases your risk for developing dementia. There's some information in the literature about depression not being treated in late life onset, as well increasing your risk. And importantly, and Mom, I hope you're listening, hearing impairment also increases your risk for developing dementia. And if you're finding you have visual impairments, it's recently been added to the list of increasing your risk for developing dementia by 2%. I'll show you that slide later. Poor sleep, very important. Lots of studies and information coming out now about how important sleep is. Fragmented sleep, not getting good quality sleep has an impact. Your brain doesn't get time to rest. There's lots of inflammation that happens. Obstructive sleep apnea, which refers to people with metabolic disease, overweight. There's disruption in their sleep. And then medications. So everybody wants a sleeping pill. The benzodiazepines, those are what we call those sleeping pills, a Dormanoct here and a little Ativan there. Definitely there is some evidence in the literature that there has been a small percentage in some of the cases where they've noticed that that does increase the patient's risk. And certain medications, such as medications that we use for allergies or hay fever, often people prescribe it so that you can sleep. So that's why they actually use the Allergex and the Phenergan. Amitriptyline, trepoline, another common anticholinergic drug, and drugs we use for overactive bladders. Now, these medications have a risk of making you acutely confused and then worsening the cognitive function if somebody is already in the process of maybe developing a cognitive disorder. So as geriatricians, we try our best to stay away from this group of anticholinergic drugs as best we can. We don't like benzodiazepines. Often patients are already on them when they come. And so we try and take them away where we can. Unfortunately, the overactive bladder treatment, it is a quality of life issue if you have to run to the toilet every time and you're soiling yourself. It is quite, embarrassing. The state does not have one of the newer drugs, which definitely has not been found to cause any cognitive impairment. And there is another option for that, but it is expensive. Okay, so what are the warning signs of dementia? How do you know if you need to be worried that something's going on? So firstly, memory loss. So again, I mentioned there's normal forgetting for aging, but then there's forgetting important things like, it's your wedding anniversary coming up this week, or you had an appointment with a doctor today, or your daughter's child's name giving. So forgetting important information that is pertinent, it's part of your everyday life. Finding difficulty with performing tasks. When your mom is sitting on that phone and she's like, I think this cell phone's not working. I think I need a new one, Not being able to work the phone, or knowing where the WhatsApp is, or, struggling with simple things like reading from a recipe. When you start to find that tasks that you normally do every day are starting to become difficult, that is something to be concerned about. Language issues, if you're mixing up words, so they see a camel but they call it a giraffe, or they're reading a sentence but they're not understanding the words. Getting disorientated, driving to somewhere all the time and then all of a sudden not sure where you are, So getting disorientated to familiar routes you've been to before, not knowing what the day of the week is, what the month we are in. Poor judgment, so sometimes speaking a little bit inappropriately, not being able to read the room and be careful with the words that you say. Poor judgment can go as far as not being aware that it's actually cold outside and you walk out in your t-shirt. Some people tend to not bathe. So those sorts of things you need to look into. Poor financial decisions, impulsive decisions, misplacing objects, putting your keys in the fridge where you would normally put them by the side board when you walk in or on the server, packing things away and never being able to find them. So struggling to figure out problems or how to, when you start with the multitasking issues again, I'll speak about the following a recipe, not knowing what step goes where and how to problem solve out of that. You'll find that patients either become apathetic, so they'll just say, oh no, I don't want to cook anymore. No, I don't want to go here. Oh, no. So they become sort of just not interested. They become depressed, or they can become irritable and just not engage. Visuospatial impairments, so not identifying the different colors or understanding that when they're at the robot they need to move, or they're driving too close to people so they're not aware of themselves in space. They're knocking around and knocking into objects at home when actually they've been living in that house forever, so they know where everything is. Their judgment gets impaired around that, and you always ask the families, are there any scrapes? Are there any new scrapes on the car, when we're trying to figure out, is their driving still okay? And then withdrawal from activities or work and social engagement. So if you know somebody where these things are happening, or you yourself are worried, then what should you do? You should go to your general practitioner. We are very blessed in Cape Town to have very many good general practitioners, and also are learning all the time and becoming more aware of dementia. And so they will assess you. They can do a little mini cog test if they think there's a problem, and they'll look first for reversible causes, because there are many things that can look like dementia that not necessarily is dementia and can be reversible. So they'll do specific blood tests. They will look at your medication. So, mom started the Detronorm and now she's been confused the last 2 weeks. There we go. We stop it. We fix it. She's great, So there's certain things that can be changed. And if there is depression, for it to be managed and treated. If they are not sure, if they are worried, they will refer to specialists. And a specialist would be a neurologist, a psychiatrist with an interest in dementia, or any one of the 3 geriatricians in private at the moment. Okay, so what happens at our clinic? We see the patient, listen to the family. We do formal memory testing. We may want other specific investigations to help us identify whether this is truly a dementia, or could it be something other reversible thing that wasn't tested. We definitely need brain imaging, because on the brain scans we may pick up tumors in temporal lobes where the main problem is just presenting with language issues. We may pick up reversible conditions like normal pressure hydrocephalus. And then once we are sure and we confirm the diagnosis, we obviously have to assess at what level the patient is, decide if there's appropriate medication we can use on this patient, see if there are any factors that are aggravating the progression of the illness. So, are there medications that we can take away? Sleeping pills, bladder pills, all other pills that they get from everybody else, Memtat. Advise to continue and improve physical activity. It's important, very important, and you'll see me mention this every time. Caregiver burnout, the person who's looking after the patient. It's important to educate the family and the caregivers, and we look and manage complications such as behavior changes, which is the major thing. But also as the disease progresses, the patients go through different stages. So we generally categorize it as mild, moderate, and severe. And what that is we decide where is the patient with their cognitive impairment in their level of functioning. Can they still safely live at home? Are they coping with cooking, organizing their meals, carrying on with their daily routine? Are they still safe to drive? These patients generally are still capable of managing their personal hygiene. They are still safe driving in familiar routes, and they're coping within their home, but they are not coping in the workspace, or if they were to have, say for example, organize an event where there needs multiple steps and informations and things where there's complexity of tasks, they are not coping. So you keep it basic, you keep it simple, they're fine, they're safe, they know how to lock their doors, they're okay. Then there's moderate a moderate degree. Here we start to notice actually the patients need assistance. They kind of mixing up their medications. Like my dad is writing all these medications down, but he took the morning in the evening, or so you start to notice there is something wrong there. You notice that they can cope within their household, but now they actually can't cook anymore. The food is in the fridge. Everybody's brought them supper, and it's last week's supper still sitting in there in the fridge. They're going grocery shopping, but they've got 20 tins of baked beans, but no onions, no tomatoes, no milk, no bread. So you're starting to realize they actually need help and assistance, and they need to be supervised from a distance but close. And then we get advanced dementia. Here patients may still be physically independent. They may still be walking around, eating themselves, feeding themselves. They don't know what day of the week it is. They don't know how to put on the stove. They don't know where they're going, but they're still physically strong, and looking well, but their brain is not functioning. And here they need full-time supervision. So they basically need a coordinator. It's when you're in the moderate and the severe degree or advanced stage, you basically got a toddler, that you're looking after. And the advanced stage requires persistent full-time supervision. So everybody asks me about the stages of dementia. We don't generally classify patients in stage 1, 2, 3, and 4. Like I said, we look at mild, moderate, and advanced, because that dictates what level of care the patient needs. That will dictate whether we would want to go in and give them any medication and give it a chance. It doesn't really affect how we manage or treat the patient, but it's an understanding for the families. And you can find this anywhere, and for the because of time, I just don't want to go over. So I'm sure you can find many of these on the internet of the different stages describing, where they are and what level of impairment they will struggle with. And in each stage, there will be problems with memory, language, physical function, behavior, and emotional instability. So all of those categories will get affected as the disease progresses. So I think for me, and I think I see this a lot, and I'm sure a lot of families also get affected, is what is the impact for the patient that actually has the dementia, and what is the impact on the family. And often it's so hard because some of the patients are still quite functional, but their insight, which is their higher order function, which is generally the first thing that goes, is that but I don't have a dementia, no, my memory is fine, they're coping, they're thinking everything's okay. And so then they find the family like they're mollycoddling them and trying to control them, but actually they're not aware of how impaired they are. And so they can become frustrated, they can become paranoid, they may think people are stealing their things, but actually they just packed it away and they forgot, it's deep down at the bottom. I had a patient who his family was quite happy, but they found ice cream tubs full of money in the freezer. Yeah. So, they can become depressed because they realize they're not as functional as they were. Their lifestyle changes, and they will become more withdrawn, and some of them can become a little bit inappropriate. Later on, they become very childlike and dependent. They become restless. We talk about sundowning. You may find that in the afternoons, just as dusk sets in, that your family member or somebody becomes very restless and agitated. And it's because they're just not sure. Because the light is changing, it's not very clearly day and it's not very clearly night. And so they are confused with what is going on and they don't feel safe. They develop sleep disturbances. They may wake up thinking they're 20 years old and on their way to work while everybody's like, what you doing, Mum? We need to go to sleep. It's 2 o'clock in the morning. Nobody wants curry now. So lots of sleep disturbances. There's a change in their day and night cycle, and they can develop significant neuropsychiatric symptoms, which is often the hardest thing for families. They become agitated, they become aggressive, they start to hallucinate, they phone the neighbors, they say, my children are locking me up, they're not sending me food. It happens, family believes it, the families get phoned, what are you doing to your mother? And it's just chaos. Okay, so when you get a phone call, just first be sure that there's no cognitive stuff going on. What is the impact on the family? The impact on the family is much more than on the patient, because the patient blissfully eventually ends up living quite a comfortable life, everybody's doing everything for them. They're coping, they're going along with things. But the family is trying to reconcile, who is this person that I'm seeing? I can't see that there's a tumor growing out their brain, so what is making them behave like this? And so it's very abstract. And you may think, are they putting on? Are they being manipulative? Or why could she do this today? And yesterday, now she can't do it. You know, so there's lots of things that start to come into play, and also that's where the family dynamics and the underlying emotional family situations tend to kind of spur those thoughts. But most importantly, anybody who's having a family member who has dementia is grieving. They are grieving that mom that they wanted to have a conversation with. They're grieving the change in role, the husbands. It is so hard for the husbands because their wives were cooking and cleaning and organizing and making everything they want, and now they don't know how to put on the stove. They don't know where to begin. Their children are overseas. They didn't plan for this. The retirement was they were going to go traveling, and now what do? The children have to give up their jobs. Their lifestyle gets changed. This partner that you were going to have long conversations with and deep discussions and pick up the grandchildren with is now not even interested in the grandchildren, irritate her. And so now you and your spouse are on different lengths. Your children can't engage with you. And there's just this loss and this grief that this family goes through. And it stages and it takes long and it's a process. And so there's a huge impact on the family. There's emotional discord that happens within the family, within the person living with the patient. It's their own guilt, their feelings towards the patient. There's just so much impact on the family. It actually is really very huge. And the caregiver eventually becomes burnt out. And this is very important because when the caregiver is burnt out, when we don't look after the caregiver, then the patient with the dementia suffers. The patient with the dementia suffers. So there's huge burden on the caregiver, financial stress, physical stress, they can't keep up, they can't cope with the patient, and emotional stress, all the grieving, everything else, they're doing it on their own, they're carrying it, you know. So very important, it's a huge impact on the family. For a family member who has dementia. So, yeah, you know, sometimes they look like this. They're suddenly ready to fight with you, and you don't know why. You just don't know why. They woke up this morning, they got crazy eyes, and you can do what you want to. They are not going to budge. You leave them. You let them be in the moment that they are in, and you give them time. They are not in control. They don't know what is going on. Yeah, it may seem like they do, and maybe they have been a little bit manipulative in the past, but their brain is not working. It is failing, and you need to find a way to manage that. You need to manage your own emotions around this person, and you need to manage that situation. So often their behavior is driven by fear of change, fear of the environment. Something doesn't look familiar. They may be sick, they may be developing a bladder infection, and because their brain can no longer compute everything at the same time, their first response is primitive, to be aggressive, to shout, because what do you do when you're scared? You react. You need to protect yourself. And that's what they do. And they maybe a lack of understanding that, you know, this daughter was tired, so Sharifa decided to take mommy for the weekend, and now she wakes up, but her room doesn't look the same. Did somebody hijack her? Where is she? And if she was somebody who had trauma before, somebody's been assaulted before, somebody was locked up in a house before, that is the response you're going to get. So it's very important to understand the patient. And if the caregiver is burnt out, the behavior gets worse. It's often the first thing we identify. So the caregiver needs to manage their own expectations and the expectations of the patient understanding. You can try, you can stand on your head, you can do a somersault, you can get their favorite grandchild in, but if she woke up today with crazy eyes, you're not getting her to do anything she doesn't want to do. And so dementia is not a disease just of the patient, it's a disease of the family, of the whole family. And there is no one size fits all. Unfortunately, I can't put everybody in a box and say, here you go. That'll make my job so much easier. I'll be like, here you go. I'll have like 20 patients on a day and just put everybody in a box, and this is the package of care we give to you. We can't do that. There is no specific package of care. But there are ways that we manage it. And I think importantly, we look at the patient within their environment, within their family situation, who is their primary caregiver. We look at their medical conditions. We try to see, is there anything there that we can alter in their medication? Are there medications we can take away? Are they actually just a little bit depressed and they need that treated? Should their bladder infection be treated? Are they developing other chronic conditions or autoimmune conditions like causing abnormal electrolyte disturbances like thyroid or parathyroid illnesses? Is there family support? Does the family need support? Are there social networks involved? Is the patient just bored, and nobody's there? What do they need? So we look at the patient within the context of them in their life, with their caregiver and their environment, and we somehow just treat everybody. Okay, so it's very important that at every stage for us that we always remember the quality of life of the patient. We want to give the patient dignity, and we need to preserve their dignity and treat them with respect. It is still your mum, your dad, your aunt, your uncle. If they're not gone with the fairies, they're not doolally, they're not a few buckets short, not a few screws short. They have a chronic illness in their brain, and they are struggling. And so it is important for us to always want to give them quality of life, treat them with dignity and respect. We try to slow down progression by, again, educating about vascular risk factors, making sure their blood pressure is controlled, that we're on top of their diabetes, that they are taking the statins and the family didn't take it away thinking that was the cause of the dementia, that they are keeping physically active. And obviously, our management would be directed according to the level or the degree of the impairment that the patient is in at the time. So it's important to engage them in activities and tasks, but that they are appropriate to do, okay? And also that they like. You can't take uncle who's never painted a picture and now put him there and say, here's watercolors, let's go. No, you need to choose appropriate tasks for them to do. So if uncle enjoyed the gardening, or like my dad loves working on his vintage, find somebody who can keep him entertained and work with him, give him things that they enjoy doing, but do it to them with supervision. So it takes time, it takes a lot of effort, and you can see why the caregiver gets burnt out. It's very important to encourage social interactions, but you may find that they do not like being in a crowd. So if they like going out, or they'll say, oh, they never take me out, It's like, but we were just at like the engagement the other day, Mom. Well, she doesn't want to be where there's so much people, because remember, she cannot process all that information that's coming at her all of the time. It's overwhelming. And I say her, but we do have men that have dementia, so please, I'm not saying it specifically, it's just women. So it's important to try and see what kind of social engagement they're comfortable, one-on-one, 2, 3 people maybe, limited time. You may find, they want to go out, and then they're like, it's an hour later, you just got to like Muizenberg, took you 40 minutes to drive there in the traffic. They're like, when are we going home? When are we going home? It's going to happen. You need to just go with the flow. Okay, so the medications we have, there is no cure. It's a progressive disease, and they manage symptoms. They try and keep the patient functional for as long as possible so they can still enjoy some quality of life and preserve their dignity, that it doesn't end up with you having to change their nappies. And everybody responds differently to the medications. Now, these drugs have only been tried in patients who have proven Alzheimer's type dementia, but we do sometimes use them in other types of dementia. And obviously, it will be specialist-driven and guided. They do not come without side effects. Not everybody responds the same way, but it's the only thing we have, and so we try and we use it to try and keep the patient functional. When it comes to the behavior, we sometimes have to use antipsychotics and antidepressants, but this we will tailor and use the lowest possible dose that we need to, and we only ideally use it if it's impacting the patient's function, safety, and there's a huge burden of care on the family. Again, education is very important for the family, for the caregiver, for anybody who's interacting with the patient, for them to understand what is happening to the patient when they are upset and angry. What is triggering that? Could it be something you said? Could it be someplace they don't like going? Are they actually living in a memory of their past and they're just not with you in the environment at the moment? You leave them, you let them be, and you let them calm down. So we give our family members skills and tools and try to educate as best we can how to manage the patient. We have support groups that we run, and then obviously guide them to the level of care that the patient requires. Again, there is no cure. It's a progressive disease, but there is always something we can do to improve their quality of life and care. There is no evidence for cannabis oils, please. There is no evidence for coconut oil, and there is no evidence for ginkgo biloba, mentat, Himalayan products, all of those things. Take your statins and don't pay 2,000 Rand for multivitamins that you're just going to wear out. Okay, so prevention of dementia, exercise, exercise, exercise. Actually, there's only one thing that can increase your brain volume, and that is exercise. No cognitive tests and tools and none of that stuff actually increase brain volume. Exercise does. So my mom always says, if you don't want to use it, if you don't want to lose it, you must use it. Mom, your hearing aid too. So you do need to keep fit. You need to engage. You need to manage your chronic medical conditions. You need to eat well. Everybody's on this Mediterranean diet. It is helpful. Why? Because it helps reduce your risk of your chronic metabolic diseases. And so therefore, it reduces your risk of developing dementia because you're controlling the chronic conditions. So whole foods, beans, legumes, lentils, salmon, fish, that's high in omega. And this you want to start now. You can't want to force the salmon down somebody who's already got dementia. It's too late. The process has happened. So these things you want to do now. Everybody who's going to reach for their second samosa tonight, just think about that. Okay, so stay away from highly processed foods, sugary snacks and meals, and just remember, good heart health is equal to good brain health. Okay, prevention, there we go. If you don't use it, you lose it. Hearing aids, people, hearing aids. You're all wearing dookies for the men. They are so tiny, you can't even see them anymore. You do need to wear your hearing aids. You have an increased risk of, I think, 2 to 3%. It's on one of the other slides for developing dementia if you have hearing loss. Challenge your mind. Try to do something different. So it's pointless if you're an accountant and you just keep doing new accounting things and you read the latest article in the Chartered Accountant Journal. It's not going to help you. Your brain's already made those connections. You want to make new, different connections. You want to learn a skill. Maybe if you didn't know how to crochet before, I don't know if the uncles are going to do that, but you know what? You can try. So learning a new skill, doing something for yourself, something that makes you happy every day, something that makes you feel of value. Have a purpose and give to others. It is such a rewarding thing. Stay socially engaged. Maintain family connections, emotional connections with good friends. Try and stay engaged with your grandchildren. There's lots of evidence for older patients who are quite actively involved with their grandchildren who actually have a reduced risk of developing dementia as they get older because the little ones are teaching them new stuff every day. They're engaging with other people. It's just a change of environment all of the time and they constantly have to be on their toes. And mindful meditation, I mean, in our religion, we have this. In fact, I think we are so blessed to be Muslim because there's so many things here that our religion teaches us that we can actually just do, you know, that we've had actually at our fingertips. So have a purpose, stay socially engaged, maintain emotional connections, be mindful, and protect your head. So more evidence coming out about trauma-related head injuries with patients developing dementia. This is the what I was talking about earlier. Just see the pointer. So these at different stages in our life, we can actually reduce our risk of developing dementia. And obviously, education in early life is very important. So if you had low education, you never reached high school, you have a 5% chance of developing dementia as you get older. If you don't, 7%. I gave it less. I gave it 2%. So 7%. If you are hearing impaired, you have a 7% chance of increasing your risk for developing dementia. And they all add up. Not taking your statins, depression, having a head injury, so physical inactivity, diabetes, smoking, hypertension. You add them all up, you can actually reduce your risk. So that's in your midlife. So here we are, people. This is where we need to go. So if any of us are sitting here, we need to try to make sure we are socially engaged. Mr. Park and his wife was already on the activity. They started early. They're doing all these talks, so they're doing strong. Air pollution is obviously a very difficult thing here, but if any of you are having visual impairments, go check that you don't have cataracts or any issues that need correcting. So there are challenges, huge challenges that we all face in dementia. I think a big thing are the behavior symptoms that start to develop. Families really struggle with that. They become very fearful of the patient. They become embarrassed to take the patient out. You'll actually be surprised how well everybody just adjusts when you explain to them, my mom's got dementia, and how comfortable and kind and thoughtful everybody is. So families really struggle with that. Patients tend to sometimes need institutionalization, so they can become really psychotic. And we don't have spaces for older people in psychiatric facilities. They'll have to sit at Grooteskier Hospital and wait 3 months to get into Stikland if they have really bad behavior. And then Stikland is the only old age psychiatric institution that we have if we need to manage the patients. And caregiver burnout. Caregiver burnout is so huge. It's really impacting caring for the patient. I think our caregivers also don't have grace for themselves, and I think we do need to understand that it's okay. It's okay to get frustrated. I mean, I get frustrated with my husband and son. I tell them the same thing over and over and over and over, but they can learn. This person doesn't learn. So a whole day, every day, it's like Groundhog Day for you. It's exhausting. Your routine doesn't change. You don't get to go out. You don't get to socialize. It does have a huge impact. So if you are a caregiver, have grace for yourself and put some things in place for yourself. We have lack of access to appropriate health care, trying to get everybody into the geriatric clinic. Dr. Sadia Patel and Professor Combrink, they are so overwhelmed. They're amazing doctors, and they're trying everything they can, but it is just so hard to get the appropriate care that we need for our older people. And then also when they are in the EC and in the emergency unit, there's no proper facilities for somebody who's got a cognitive disorder to understand, or a safe space for them to sit. They're just lumped with everybody else. Our knowledge and understanding, and I think this is where we're starting, there's a lack of a community awareness of what a dementia actually is, understanding how to manage it, understanding how to manage the patient, and knowing what we could do to prevent it. There's very limited resources for home-based care and support services for families and patients with dementia. We have very little respite care facilities. They're all full. Everybody's on a waiting list. Not everybody is friendly or halal friendly and actually cater for Muslim people. And then it's very expensive. It's very expensive to care for an older aging person, but to care for them and they have dementia, it's even more so financially taxing, not just on the family but also on the state, because they access healthcare much more when they have challenging behaviors. So take home message, not all memory loss is dementia. Dementia is a collective term for disorders that affect the brain. Alzheimer's is a type of dementia. If you correct the modifiable risk factors, you can reduce your risk of developing dementia significantly. It's a whole family disease. There is no one size fits all in the management. You must manage your expectations. You must manage the patient with dignity and respect always, and you must take care of the caregiver. And there are some resources, Dementia Essay, Alzheimer's Essay, and if you click on our clinic website, there's a tab that has useful links. There's links to OTs, neurophysios. We now have no affiliations with these groups, but we put it there so that our families have access to it. We do offer for our families a support group, some online. We have a social worker who's offered up her time, and she, if you check on the website, you'll get the information. She runs a support group and just listens and kind to guide and help people, and we encourage families to participate. Shukran. Sorry, I know that was long.
Okay, so ladies, don't look so worried. I've got very good news for you today. load shedding has been suspended. Okay? So you can be here as long as you want to. My wife is very happy at the back. But yeah, I think you'll all agree with me that that was an absolutely brilliant presentation by Dr. Fahima Parker. Once again, your hands for her, please. Doc, let me say to you that I'll have to come and see you tomorrow, because I keep on being told that the hearing is going down. I keep on being told that I'm forgetting. So Parker will have to come and see Dr. Parker. Let me just mention to you that Dr. Parker called me a couple of days ago, and she said that she would like to make the presentation as simple as possible so that people can understand the medical condition, and I think she's done that today. Just very simple, but very in-depth, and I think highly appreciated. For me, there were two take-home points. Maybe you'll share that with me. The one was the importance of a caregiver and how to care for a caregiver. And secondly, and this really, I think is going to be stuck with me for a long time, it's not only a disease of the person suffering, it's a family disease. And I think those are very important points. And once again, you've empowered us today. Shukran to you. May Almighty Allah give you long umr, inshallah, without dementia. And may you always be that, and we've been there, so we know what we're talking about. A wonderful person. When you are in the rooms, it's not a Dr. Parker. It's just a person trying to help you. Once again, your hands for her, please. The second panelist today, another amazing gentleman. And I say these things because I'm proud of our community. Dr. Yusuf Patel, a medical practitioner, a very close friend of Qari Nadim Dawood and Sheikh Saadullah Khan, did 1 year at Medina Institute, and 5 years Alim course at the Darul Uloom Al Arabiya Al Islamia in Strand. Have I got it right? 5 years. His speciality is neurology, and today Dr. Yusuf Patel is going to be giving us, in addition to the medical perspective, a spiritual angle in terms of relating to the person suffering from dementia. Your hands for Dr. Yusuf Patel.
That's perfect. Can I close the computer? Is it fine? Shukran. بسم الله الرحمن الرحيم الحمد لله رب العالمين وصلى الله على سيدنا محمد وعلى آله وأصحابه أجمعين السلام عليكم ورحمة الله وبركاته. Alhamdulillah. First and foremost, I'd just like to say thank you to Masjid al-Quds for putting together this topic and the seminar and workshop. This is a really important area to me, specifically with regards to disease and neurology and neurocognitive disorders. It's an intersection between many interests of mine, that of neuroscience, that of religion, spirituality, and bioethics. And I think it's an area that we as a Muslim community have fallen a bit short of. So alhamdulillah, with today's workshop and presentations, I think we're moving in the right direction. So I'm very pleased to be here. And I also like to say thank you to all of you for coming out and for being present and for engaging, I think, with us and Masjid al-Quds with regards to this topic. I'd also like to say thank you to Dr. Fahima for an amazing presentation. There's nothing for me really to add from a medical perspective. I think that was very comprehensive and very empowering. And really what I want to do is to focus on religion and focus on spirituality as a vehicle for us to come to terms with disease. And we'll try to focus on dementia or neurocognitive disorders, but we can apply this, I think, across the board to all disease processes that we may face or that family members may face or people within society may face. Now I want to start by, and I know I have 15 minutes, so I'm going to be I'm going to try to be as quick as possible, but try to cover the relevant points for all of us. So I want to start by just sort of setting a foundation. I want to give you an interesting fact. Maybe some of you are aware of this, maybe not, but this is a very interesting fact that I came across a few days ago. Since human beings have been on this earth, the majority of human beings, about 60 to 70%, have not lived beyond the age of 20. Just let that sink in a bit. From the beginning of history, from when the first human being came to earth until now, the majority of human beings that were born and came into existence have not lived beyond the age of 20. It's really in the past 100 and 150 years that life expectancy has increased. And so the fact that many of us here, if not all of us, are beyond the age of 20 is really a bonus if you think about it with regards to human existence, that Allah subhanahu wa ta'ala has allowed and facilitated for us. And obviously there are reasons for that, that being the improvement of lifestyle, of society, of industrialization, healthcare, food security, etc., etc. But the mere fact that we have lived beyond the age of 20, right, that in itself should make us reflect upon the gift of existence. And that is ultimately the greatest gift that Allah subhanahu wa ta'ala has given us, is the gift of existence. And so what that means is that as our life extends, or the expectancy of our life extends, we will now face new challenges. There are new frontiers that we are going to face as human beings that other human beings historically did not experience. And some of these challenges are with regards to health, and specifically with regards to degenerative diseases or neurological degenerative diseases that other human beings over the past 200 years or prior to 200 years from our current time probably did not live to actually experience or go through a process of their bodies degenerating. Right? And that's important for us to keep in mind, as I said, because it should instill within us, I think, the spiritual tool of appreciation, what we term in the Arabic language shukr, right? To appreciate and to be grateful to Allah subhanahu wa ta'ala for what we have, and then to recognize that when we have certain capacities that others do not have, that should make us extra grateful. But more importantly, as some of the scholars have stated, true gratitude is when you use the capacities and the gifts that Allah has given you for the purpose of what they have been given. And so again, that should make us reflect, such that we should ask ourselves that whatever Allah has given us, do we use those gifts and those capacities in His obedience and for the right purposes? Now, the concept of disease and of suffering is very central to the Islamic tradition. And I suppose if you compare this to other traditions such as Christianity and Buddhism, you have this notion of suffering. And whilst the modern world has taken a very nihilistic and atheistic approach with regards to our lives, religion gives us a vehicle to come to terms and to understand and to bear the difficulties that diseases and death brings us. And one of the points that I wanted to really emphasize for all of us is that the Quran speaks about illness. The Quran speaks about the loss of cognitive faculties. As we know in Surah Yasin, this is a verse that we recite on a daily basis, especially now in the month of Ramadan, where Allah subhanahu wa ta'ala says, وَنُعَمِّرْهُ نُنَكِّسُهُ فِي الْخَلْقِ أَفَلَا يَعْقِلُونَ. The translation meaning that those whom we extend their lives, we will revert them. Nunakishu means to revert or to change or to take back in creation. أَفَلَا يَعْقِلُونَ. And so we see here that there is the cyclicality of life. We go through phases from childhood where we attain certain skills, we attain certain capacities from our environment, from our families, etc. But then we also go through a phase of life where we plateau, and then if our lives are extended by the grace of Allah subhanahu wa ta'ala, then we will go through this phase where we will revert back in creation. And as Dr. Parker mentioned and went through those phases for us with regards to the severity of different diseases, we see that the Quran speaks about this. And so the Quran is calling our attention to take this into account. But the fundamental question is, how do we respond to this as human beings? How do we respond to this as individuals? And as I said, religion is at the center of how we should respond to all challenges that we face in our life. I know the topic that was given to me was spirituality, and I have a different understanding of spirituality. I know that there are conventional understandings and there are traditional applications of spirituality, right, in terms of extra rituals that we may do in our lives and so forth, or meditations. But I think within the Islamic tradition, spirituality is embedded within Islam itself. And that when we understand the purpose of our lives, we understand what God is expecting from us, and we're able to appreciate those purposes and apply it within the rituals of religion. And we're able to get to the essence of our religious experience with Allah subhanahu wa ta'ala, then we become spiritual. I feel that over the past 50 years, you have this concept of New Age spirituality, which has really sort of degraded spirituality just to a set of rituals and, incantations and recitations. But for us as Muslims, I think it's important to recognize that spirituality is within our religion itself, and that one does not necessarily have to add anything extra to be spiritual. Rather, you need to go internally and ask yourself and connect to the purpose of life and connect to your understanding of what God expects of you, and then to live with that purpose. That's what makes us spiritual. And so keeping that in mind, I want you to go through just four different spheres with regards to how religion and spirituality can be applied with regards to disease. So again, I know the topic is dementia, neurocognitive diseases, and neurodegenerative diseases, but I think this can be applied across the board to all forms of illnesses and diseases. Just an interesting resource for perhaps some of you that you can look at afterwards. There was a great Turkish scholar, his name was Said Nursi, and he wrote a very important tafsir or exposition called the Risale-i-Nur. And one of the chapters in there was a booklet, an exposition, which was termed The Letter to the Sick. Right, and I believe you can get this translation now at most bookstores. And I think this is a very important compendium to have, because he goes through the spiritual values or the spiritual lessons that we can take out of illness and death. And I just wanted to mention a few, focusing on various spheres. Now, the first sphere is the sphere of the patient, of the individual, right? So, as Dr. Parker mentioned, in the early stages, there might be some minor symptoms. The person might have some minor memory issues, some behavioral problems, etc. But the person is still able to function. And the person is still able to understand to some degree that they are now suffering or that they have been afflicted with a disease. And so that immediate response to learning that you have a process, that you have an event in your life that is going to change the path of your life, is extremely traumatic. And such a person at that early stage where they can still process to some degree, they have to go through some process of understanding and finding some meaning. And again, religion is what gives us that vehicle. But I'm not going to stand here today and to tell you if any of you have gone through such a circumstance, or if a family member of yours has gone through such a circumstance, that you must just accept that you now have a disease, right? It's a process, right? There's a process of bereavement. Dr. Hussein will speak about that a bit later. But ultimately, what we need to recognize from this disease or from this event that has been alerted to us is that it should remind us of where we are going. Obviously, we have a life, we have ambitions, we have motivations. And when a certain event is placed upon us without us expecting that, it changes us dramatically. But it should just return us to the beginning in understanding that Allah subhanahu wa ta'ala placed us on this earth for a purpose and that we will return. And so to some degree, one can look at this as if Allah is raising a flag to remind you that first and foremost, that you are dependent upon me, that you as an individual are impoverished in relation to me. And so therefore, you are dependent on everything for me. And then secondly, that your life at some point will come to an end. And I think one of the greatest travesties that we as human beings have experienced in this modern period over the past 100 or 200 years with modernization is that we have really forgotten the fact that we're going to die. If we go to our workplaces, if we speak to people, if we interact in social gatherings, it's a taboo to even mention death. On a personal level, we are not psychologically ready to accept the fact that we are going to die. Even though people pass away, our family members move on, right? Death is a constant that we see every day. The fact that we as a religious community, we come to the mosque to perform the rites upon those who have passed on. So we see death in front of us. It is just that as human beings, we have forgotten, perhaps it's willfully, in order for us to compensate for the fear and the apprehension of the notion of death. But disease and illness allows us to come to terms with the fact that we are all going to return to Allah subhanahu wa ta'ala. You know what's interesting, and perhaps some of my panelists can comment on this later, and the medical practitioners in the audience, we see death on a daily basis. We have to give bad news to patients. But do we actually ask ourselves, do we take lessons when we have to give patients the bad news that they have a terminal illness, or that when someone passes away in front of us in an acute emergency or so forth? Do we actually take the time out to reflect on the fact that we are also going to die one day? Or do we just carry on with our lives? Do we just carry on with our work? Do we just carry on with our plans, our expectations that we have crafted and created for ourselves? So I think this is an important point that we need to understand. The patient has to come to terms with regards to their mortality. And that obviously takes a process, and that takes support structures. Now, the next sphere is the sphere of the family. And Dr. Parker mentioned that and went into a lot of detail about that. And as she mentioned, and I 100% agree, I think the family to some degree takes the greatest burden with regards to care of the patient. Because all of us, we have, as I said, we have ambitions, we have motivations, we have plans, milestones that we want to achieve in life. If all of a sudden a family member, God forbid, our parents, our grandparents are diagnosed with a terminal illness which will require our assistance, that just detracts from everything that we have created for ourselves and we have placed in front of our eyes. And so now the family members, the close family members, have to find a means of spiritual resilience. And what you can find from this, or what you can find from religion, is the fact that service, the concept of khidmah, is central to us as human beings. What I was reflecting upon when I was thinking about this workshop was the fact that we as individuals, we all have this concept of what is our purpose in life. We all go through this at some point, whether in our adolescent, in our middle ages, or even later on in life. We ask ourselves this fundamental question: what is my purpose? What do I need to do with my life which will bring meaning? And then we might create that for ourselves. We might build that up with time, with our studies, with our business endeavors, whatever else it may be. But then when something like this happens to us, where we have to take care, where we have to really sacrifice from our time, from our finances, from our lives for our family members, we somewhat become frustrated. But the reality is that this should actually be the opposite. We should understand this in a different light. That whilst we thought we had a certain purpose, here Allah has placed a circumstance that we had no control, right? So Allah subhanahu wa ta'ala has predestined this for that person and for us, because we are related to that person. And so now our life purpose, our purpose, the meaning that we were searching for, in reality can be found in serving and in assisting and being there for that individual that is requiring our assistance. We might not like that, we might not like the circumstances that may bring, but with regards to our personal spiritual elevation, that might be the message, or that might be the opportunity that Allah is giving us in order for us to elevate ourselves for the year after. And the last sphere that I would like to focus on with regards to our religious and spiritual experience is the communitarian aspect. Now, this can include two segments. This can include distant family members, friends of individuals and families that are afflicted. And I think here the purpose really is to ask yourself, how can you assist? Right? Obviously, you might not be there on a daily basis to assist the individual with their daily needs, but there are many other ways that we can assist with regards to helping people in difficulties that might be, again, financially, just emotionally supporting the caregivers of individuals that are going through that, finding ways that we can create support groups for others. And again, this becomes a means of spiritual elevation for you. But another interesting aspect as a distant individual from someone who is sick or ill or suffering is that if you take lessons from the circumstances of others, where you now realize and recognize that you still have your cognitive faculties, that you still have certain faculties that that person no longer has, you now start appreciating the gifts that Allah has given you. And the beauty of this is that when you realize this and you apply yourself based on that, that person that is suffering, that person that is going through that difficulty, that becomes a sign for you, will now be rewarded because they were a means for you to have changed and to have elevated yourself. And I think a lot of us go through this currently now with regards to what we see in places such as Gaza, Palestine, and in other areas of conflicts. Yes, we can contribute financially, we can contribute in certain ways, but many a times we feel very distant to the place because we cannot be there physically to actually help people on a personal basis. But if we can take lessons from their suffering, and when I say their suffering, we look at their resilience and we appreciate what we have, and that motivates us to apply ourselves and to do better and to prosper with those gifts and opportunities that Allah has given us, then that will allow us to spiritually elevate, and it will elevate those individuals who are serving as a sign for us. And the last part with regards to the communitarian aspect, right, is that on an institutional level. What can we do in order to support individuals that are going through difficulties with regards to diseases, right? As Dr. Parker said, I think there's only one state facility at Stikland where people can actually go to if one does not have other financial resources. And I think that's very shocking for us within our community, because that shows the lack of resources that we have. And I think as a Muslim community collectively, right, we should be looking to establish institutions that can assist people with all different types of illnesses. And specifically with regards to neurocognitive or neurodegenerative diseases, we should be looking to create institutions, nursing care facilities, healthcare facilities, whereby people can go there and find some solace and find some assistance. Now, I don't want to be controversial, but I think we need to change our paradigm and we need to change our mindset, right? Alhamdulillah, Allah has blessed Cape Town, has blessed South Africa with many masajid, many religious institutions. But I think our business community and those individuals that have the resources should now be looking to invest and to focus their financial resources within such structures. And so, whilst it's good, alhamdulillah, may Allah reward all those who have established new masajid in various areas, I think we need to move away from this concept of just creating more religious institutions. We need to create more social institutions that will provide a religious benefit or a spiritual benefit for all people. Again, I'm not being controversial. I've studied religion, alhamdulillah, so we understand the value of the establishment of masajids and so forth. But as we know, today, if we go to a mosque, many of the masajid are not full in themselves. So I think we need to look beyond just creating and establishing and building new mosques moving forward. Let us look at such initiatives whereby we will be able to assist the broader segment of society, not only Muslims, the broader segment of society with regards to managing and being able to face illnesses and diseases. So I just wanted to end by saying that ultimately the greatest sign of spiritual maturity is when we come to terms with our mobility and with our mortality. When we realize that we are all going to die one day, it will motivate us to focus on what's important, to focus on serving and helping those who are important to us, and adding an additional value to society in whatever form that may be. So, shukran for the time. Assalamu alaikum wa rahmatullahi wa barakatuh.
Shukran to you, Dr. Yusuf Patel. As I was listening to you, I remember somebody saying, I don't know who the person is, but this person mentioned many years ago, human beings are very strange people. Said, we always yearn for paradise, but we fear death. But thank you very much for a very good spiritual angle to our seminar here today. You've highlighted the point that Muslims should always be people of compassion, and I think that's very important, an important hallmark of our deen. And then the final statement that you made, and you don't have to worry about being controversial, because I think at this mosque we are very controversial. We like to grab the bull by the horns, and there are many business people here, and I'm sure they've taken the cue that we need to move in a different direction, and inshallah, Allah willing, that will become possible, inshallah. Ladies and gentlemen, our final speaker for today, and I said earlier, we've got a very prolific panel. He is a distinguished clinical psychologist, an associate professor linked to the University of Minnesota in America, holds multiple PhDs, qualified counselor, and I can speak on behalf of the mosque here. He does wonderful voluntary counseling work at Masjid al-Quds. Your hands for Dr. Hussein Ibrahim.
Assalamu alaikum wa rahmatullahi wa barakatuh. No, I'm not going to use it, no. I'm not going to use it, it's fine. No. I initially thought I'm going to use the laptop and do a PowerPoint presentation, but I'm going to pull back from that. Our two distinguished speakers have covered much of what I would have liked to say, and I accord good sayings there. I appreciate them looking at it from a very multifaceted perspective. However, there are certain points I'm going to make before I go into looking at what psychology really is with dementia. And I'm going to be concentrating a lot on the caregiver, because at the end of the day, that's where most of the, if I can put it for lack of words, the problems are. But before I start, I would like to make a few comments. I'm not very well versed with where the verses of the Quran is, and the learned people here can maybe rectify me, but I believe that there is a verse in the Quran that actually says Allah subhanahu wa ta'ala has created the human being with anxiety. What does that tell you? It tells you that all of us have anxiety. Yes, to certain different degrees, but we've been created with anxiety. We need to learn how to live around it. The second point I would like to make is that as caregivers, we go through hell. And I say that very strongly because many a times as caregivers, we are disregarded. It brings me to something which I experienced personally, and I always like to tell the people who come and see me that when we make dua, we say, "Oh Allah, grant the patient shifa kamila." This is the first thing we say when we hear somebody is ill or somebody is going through some illness. But added to that, something that we have to say is, "Oh Allah, grant the caregiver the strength to look after this patient." Because if that caregiver can't help that patient, it's not the caregiver that's going to go through hell, but it's the patient. And that is why I want to shift the whole thinking process from patient as primary. Please don't get me wrong, I'm not saying that is not important. Yes, that is important. But look at the caregiver as well. Having said that, I just need to briefly identify some of the symptoms that both caregiver and patient goes through. And I'm just going to enumerate some. I mean, I've got here about 20 some odd symptoms. But just to enumerate some: anxiety, which is primary on the list; depression, caregiver and patient. Patient goes through depression. I was functional, I was in control, I was running the household, I was the breadwinner. Wherever you come from, now you realize that that control has been taken away from you. And if that control goes away, you feel that you are worth nothing, which brings you to what is a low self-esteem. Okay? This leads on to the patient going into an argumentative state. And when I say argumentative, what's wrong with me? Doesn't forgetfulness come with old age? I can't do this anymore. But isn't that natural for an old person? And to move that person's thinking process from, yes, you do forget when you become older. Like Dr. Parker mentioned, that you have loss of memory, you have your memory processes slow down. All these things do happen when we become older. But there's a fine line of what happens and what happens when it's dementia. And that is what we need to distinguish. And then we as caregivers, we need to realize that, hello, there is some information here. There's something that I need to take note of. Okay? But because there is this lack of support for our caregivers, we go into that depressed state as well. We just feel, how much more can I do? Just like what the patient feels, how much more can I take? And remember, something I always use in my counseling, that Allah does not place a burden on your shoulders heavier than what you can bear. Yes, you are going through it, you know, and you say, how much can I bear? But take into consideration that saying, that Allah does not place a burden than heavier than what you can bear. And that would help you primarily in able to cross that line where you can say, I am here, and together we are going to do it. Easier said than done? Yes. Easy for me to say that together we are going to do it, because you need to convince that patient that yes, you have dementia, and it's not only in dementia, it's any of the illnesses like Dr. Patel mentioned. It can be any illness. But we're specifically looking at dementia here, so I mentioned dementia. You need to convince that patient that is what you have. And when you can convince that patient, listen, that is what you have, but here is my hand and we can walk through it together. Okay? And as Dr. Parker mentioned, that it's not something you're going to get rid of. Okay? It's something that you have to learn to live with, and it gets worse, it degenerates. Because what is, and maybe Dr. Parker and Dr. Patel can correct me, dementia is actually brain cells that are dying down. And like your whole body, there are parts of our body that gives in. Your heart is not pumping as strong as what it used to do when you were 20-year-old. So we need to take that into consideration. And we need to say, yes, you know what? It's going to be difficult. I'm stretching my hand out. How far are you prepared to stretch your hand out? And that patient will only stretch out the hand if he or she they have come to terms that that is what I have. And sometimes, I know in practice, sometimes you have to be cruel to be kind. You have to tell the person, listen, this is what you have. And there are the proofs. You've done the imaging, you've done the blood tests, you've done all the tests. This is where you are. And if it's not attended in that way, you're going to land up with psychosis. That patient is going to develop psychosis. I'm not even going into the depression and the whole mental issues that the caregivers or the family is going to go through. So we need to convince primarily the patient that this is what you have, and this is how we are going to handle it. But it needs to be done in a very diplomatic way. It needs to be done in a very positive way. It mustn't be demeaning. And like Dr. Parker mentioned, that the dignity of that person is so important. And what spoils that dignity, if I can put it that way? Lack of bladder control, lack of sleep, lack of normal functional controls. Not simple issues of not remembering, putting the keys in the fridge, for example. Okay? The person will say, you tell the person, but you're going to walk out and you're going to forget where you are or who you are. And the person says, there's nothing wrong with me. The fact that I've come here to see you, there is nothing wrong with me. Why did I come here? The fact that that person is asking, why did I come here, shows you three things. Denial, sweeping under the rug, and you know what? I'm still in control. I can still walk. I can still sleep. I can still eat. And yet those are simple functions which get affected. So we need to, one, be realistic as caregivers. Like I said, my presentation is looking primarily at caregivers because that is going to be the source of help. Okay? So we need to take into consideration as caregivers that we need to be positive. There are days that you are going to be down in the doldrums. It's a roller coaster. Okay? But remember, you're going to climb up again. You're going to take the bull by the horns again. And you need to do that. Not only for your own sanity, but for the sanity of the patient. It's twofold. And that's what makes your burden as a caregiver just so much more difficult. So, primarily, caregivers need the support as well. And you as a caregiver must not feel ashamed that to say, I need help. And that's where your support groups come up. Okay? Go out there, empower yourself. You need to empower yourself because you are going to help somebody else. We are all in a helping game, like Dr. Patel mentioned. One of our primary functions as Muslims, we need to be helpful. So go out there and get the help. It's going to alleviate, it might not take away completely, but it's going to alleviate the depression you go through. You might not recognize that depression. But the fact that you are taking the patient for help, you are crying out for help as well. Recognize that, because that is going to make helping the patient just so much more easier. You know, the person who actually goes through dementia might just find that I can't do the shopping now. Like Dr. Patel mentioned, I mean, you put 20 tins of baked beans in the trolley, okay? And how do we as caregivers react to that? What's wrong with you? Why are you taking so much baked beans? And yet it can be done in a positive way. You know, I look at a lot of what gets done with dementia patients because they are now toddlers. They become babies, okay? And how do we handle children as parents? We need to look at it from a positive perspective. Instead of telling the child, what the hell is wrong with you? Why do you do that? You need to speak more positively to the child. This is a child you have, so handle that person in a positive way. That same issue of saying, what are you going to do with 20 tins of baked beans? You could turn it around and say, 20 tins of baked beans is quite a lot, but we need sweet corn and we need this and we need that. It's saying the same thing, but in a positive way. As a caregiver, look at the glass half full as opposed to half empty. Because when you are going to look at it half empty, you are going to become frustrated. And when you become frustrated, that's when you lose faith in the Creator. That's when you question and say, how much more can I take? You are justified in saying, yes, how much more can I take? But rather let that statement be, how much more can I take? Oh Allah, guide me in this. Oh Allah, give me the strength to be able to weather this. I mean, many a times we sit on our musalla and we say, Allah, take this burden away from me. And yet, you can turn it around and say, Allah, you have given me this burden. I didn't ask for it. You have given it to me. So give me that strength to be able to cross this burden. And that makes you so much more a resilient person. And especially for us as caregivers. Just turn your whole mindset around. So I say, let's look at the burnout of the caregiver. Okay? And I'm going to mention some of the things that we as caregivers go through, and it's some warning signs. And I've sort of narrowed it down to 10. The first one is denial. We don't want to see our loved ones go through something like this that can be dehumanizing. Dehumanizing because if that dementia becomes more extreme, it leads to other subsets of dementia. I mean, I've had a patient that, I don't like to call them patients, but I had a person who would get undressed in the middle of the road, defecate or urinate. Okay? And how dehumanizing is that? The patient is not aware of what he or she is doing, but for us as family members, for us as caregivers. And what happens is, because we know that it can lead to that, we deny it. We want to sweep it under the rug. Denial also comes, we don't want to go out and ask for help. We are burning out in the meantime. And we cry out for help silently. But we don't want auntie, uncle, brother, whoever. We don't want them to know that we can't handle it anymore, we need help. Okay? So we go into denial, we sweep it under the rug. Second warning sign, we build up a lot of anger. We say, again, what question? You start questioning. And you build up that anger. And you know what happened? We as human beings, we bring over a lot of unconscious behavior, non-verbally, how we react. okay? Our facial expressions, our body language, all this adds up, and they are sometimes very perceptive. They might have loss of memory, yes. I mean, the person will say, what did I do wrong? Okay? It's not what you've done wrong, but it's what you are showing unconsciously. Because you, as a caregiver, are going through hell. You feel how much more. You feel that you are making the effort to look after this person, and this person is not appreciating what you're doing. Okay? And yet it might not be that way. It's just that this person's thinking processes have gone, and for lack of words, wonky. So you need to take that into consideration. Next important warning sign, social withdrawal. We as caregivers, we step back and we say, I don't need your help. I don't want to go out into the community because I'm going to be embarrassed. I'm going to feel that there's something wrong with my father, or there's something wrong with my uncle, my aunt, whatever, whoever the patient is that's suffering from dementia. Okay? So what you have is you have social withdrawal. And yet, as Dr. Parker mentioned, is they need to go out. They don't need to go into a function of 500 people. Even mixing with 2 or 3 people. Just, it makes them feel, the feeling that comes is, I feel good, I can talk, it builds up the self-esteem, because at the end of the day, that self-esteem is going to help this patient have quality of life. The patient might not be able to do the things that they normally do. But to a certain degree, they're going to feel good about themselves. And see how the circle goes around. They feel good about themselves. They are less demanding on you. Your work becomes a bit more easier. And it just goes around and around and just becomes stronger. Yes, there is the end to it, like Dr. Patel mentioned, that death is there inevitably. But death is not only to them, it's to all of us. It's the end of our journey. But why can't we give quality of life to them? We look at a cancer patient, we can put them in hospice, give them the quality of life. So I'm not saying put a patient into Stikland or something like that, unless it becomes necessary. But even at home, if we can give them the quality of life, why not? It's going to make it easier for you as well as a caregiver. Then what I mentioned, primarily anxiety, because you don't know what to expect, you don't know where you are, you don't know. Maybe you know what dementia is, but how this patient is going to react at different times, that builds up an anxiety in itself. Secondly, you don't know how good you're going to be, because that's how you feel. In caring for this patient, that causes anxiety. Just the thought processes builds up this anxiety. That leads me to something very important, which is depression. Okay, and like I said, depression can become extreme not only in the patient, that can lead to psychosis, but alhamdulillah, we as Muslims, we don't believe in committing suicide, but there has been cases that depression has led to that, and it's a reality. We need to recognize that. So don't let your depression become that. Exhaustion. As a caregiver, you become very exhausted, okay, which leads to sleeplessness, okay, and like Dr. Parker mentioned, just don't go on to the sleeping tablets. I believe that many, and with due respect to our medical profession, many of the medications they Schedule 5 drugs, and it becomes something that you can't live without. Okay, it becomes very addictive. It's something which I feel very strongly about. I mean, I deal with children with special needs, and I look at autism, where Ritalin gets prescribed just for I don't know. I'm saying it very, very restrictively, but for the ease of the teachers and for the sanity of the parents. But what are we making out of our children? Druggies? Okay. The same here. If we can use therapy, I'm not discounting medication, because in many of the dementias, and I'm sure that Dr. Parker and Dr. Patel would actually agree with me, that there are certain medications which is needed for the help of these patients, okay? Let alone something that could be helpful to the caregivers as well. Another warning sign, irritability. We become very irritable because we don't know what to expect. We become irritable because the workload is becoming so much more, okay? And it just goes on. The list is so lengthy. Number 9 on the list, we tend to lose concentration. We tend to lose concentration because there's so many other things that we need to see to. We can't really say we're going to sit down and we need to get our sanity back. Okay? And one good thing is, as caregivers, just take that 5 minutes off. You're entitled to. Go and meditate. Take the Quran in your hand. Read some verses. Read the translations. There is so much wisdom in the Quran. We just need to go to that verse. You know, I mean, we are so open to Google, the internet. Go onto the internet or go onto AI and say, I want a verse that relates to dementia. You won't get a verse that is directly mentioning dementia, but something that alludes to it. And you'll find so much solace in it. You know, we as therapists, we have to offload, because we see so many patients and then we start internalizing a lot, and we need to have somebody that we can go and talk to. Here you have a ready-made book that Allah sent us. Okay? Go and talk to the Quran. Not only let the Quran talk to you. And Allah is listening. Whether you're sitting here, whether you're driving the car. You know, I mean, I remember in a talk just now recently, it was one of the Jummah talks, where the Sheikh said, you don't only have to read the Quran, you can put it on in the car and listen to it as well. You know, I mean, and we are, like I say, we are so computer literate, we are so Google literate. Use it to your advantage, okay? And then the last and important point, as a warning sign for us as caregiver burnouts, or the burden that we are going through, is your health problems. If you don't look after your health, how are you going to care for that person that's suffering dementia? So don't neglect yourself. Don't say, I can manage, let me do this. If you're not going to look after yourself, you can't look after that person, and that's where you are going to burn out. You are telling that person, you need to look after yourself, I need to help you, but you're not helping yourself. So even that 5 minutes that you take off, that you can do, meditation isn't necessarily just sitting with the Quran. Meditation is sitting back and thinking, what is really going on? Let me make some sense to this, because that gives you peace of mind as well. So take that 5 minutes off, okay? So these are 10 important warning signs that the caregiver stress, that the caregiver is stressing. And you need to take that into consideration. I am going to end off with some remarks that I would like to make. And the first one is, I call them the 6 C's, which we as caregivers need to use. And then maybe introduce a care plan that we can use to assist. And the 6 C's is basically, number 1, communication. You need to communicate. You need to communicate to others for help, to support groups, to the dementia patient, communication is of prime importance. The second C, have compassion. Have compassion for the patient, but also when you speak to others, like Dr. Patel mentioned, it is uncanny how the next person who comes to know that this person has dementia, how they change their attitude, how compassion comes in, how they ease with looking at this person from a critical point of view. The third C, have the courage. If you don't have the courage, rather step back and get other help in, because you're going to do the dementia patient more harm, let alone the rest of the family. Remember, many of us are not only caregivers for the dementia patient, but we're also caregivers for the rest of the family. As mothers, you do your cooking, you do this, you do that. As the person who brings the bread home has to go out and work. So we primarily have other caregiving jobs, if I can put it that way. So you need to have that courage. The third C that I would like to, or the fourth C that I would like to look at is commitment. How committed are you? Don't do it because you are expected to do it, because you are a spouse, you are a child. Have that commitment, because like I said, your unconscious behavior comes over non-verbally, and the patient can pick it up very, very quickly. The next C, competence. Go to these social groups, support groups, and get that help, get that information, get educated, see how you can better yourself. I am not saying as a caregiver that you are not doing your best. You are trying your best, but sometimes there are better ways of looking at it. Like, and I always use this as an example in parenting. I say, we parent to the best of our ability. A lot of our parenting habits are brought in from how we were brought up. And believe me, there's nothing wrong in it. But there are better ways of doing it. Okay? So go there and get that competence. And then lastly, care. Care not only for the patient, but care for yourself. Okay? If it means that you need to go out one afternoon and just walk around in the mall, do it. Okay? But then don't neglect the patient. Give the care to the patient as well, because maybe that patient needs time out as well. Maybe you as a caregiver, you are hovering over that patient, that you're not giving the patient the space. So within means, give the patient the space so that they can actually feel that, you know what, I can do it. Okay? And if they can't, and that's why I say within means, put certain checkpoints into place so that you're not neglecting it. They won't become a harm to themselves, because that at the end of the day is dementia, because they don't know what they're doing, so they harm themselves. And that is the 3 C's that I think you need to look at. And I'm just going to read out something to you, something which I thought is appropriate, and it sort of boils down to a care plan. A dementia care plan helps people with dementia maintain their independence and quality of life. It may include activities, medication, safety measures, and support for caregivers. And that, in essence, is what I would like to basically tell a caregiver as to what needs to be done. So in general, if you feel stuck in a caregiving situation that is not working and feel unable at any time to find alternatives, if you are alarmed or unhappy or dissatisfied with the ways you are behaving or reacting to the patient, it is wise and responsible to seek professional help. I just like to end off in a comment from Dr. Patel. And I take my hats off for Masjid al-Quds. That it's one masjid that has really come to the party. And I say this because I know how I extend myself, and they have accepted that extending in a very positive way of doing voluntary counseling here at Masjid al-Quds. It's become very functional. So much so that initially we started off on a Thursday morning, and now it's gone to a Wednesday and Thursday, and now it will soon go to a Monday, Wednesday and Thursday. The need is there, okay? We have many, alhamdulillah, I'm maybe in a fortunate position where I'm semi-retired and I can give back to the community. But you don't have to be in that situation, and my invitation, I mean, I don't know if I'm overstepping the line here, but the invitation there is to other professionals to come out and extend that help. Our community needs that help. And it's only when you are involved in a situation like this, you realize, and I'm going to use a very lousy word here, you realize the crap that's happening in our community. I don't need to tell you the counseling cases we get here. It's not only dementia, it's everything. And we need to, like Dr. Patel mentioned, we need to make our masajids functional. It needs to be the hub of everything. And this help doesn't only come from professionals, but it comes from the community as well. Like you say, as a caregiver, what can I do? You can educate yourself. And in educating yourself, you're going to impart knowledge to others who are in a similar situation that you are. And isn't that sadaqul jariyah in essence? So, what I'm saying is we can do it together. You need help, you can contact us. You can contact Zahira here at the mosque, and you can get an appointment. Come and see us. Because in me helping you, you can help somebody else. Jazakallah.
Thank you very much, Dr. Hussein Ibrahim, for the psychological aspect of our seminar today. So there we have it, ladies and gentlemen, a brilliant medical perspective, equally brilliant spiritual one, and of course now that we have Dr. Hussein Ibrahim with the psychological one. It's not easy. I know the whole topic of dementia is not easy, but Dr. Ibrahim has honed in on the importance of the caregiver. And maybe it's important just to remind ourselves that the caregiver is not only the person that you're paying, who has the uniform, that comes in and goes home. The caregiver is everybody at home. And I just want to share with you, we're actually running very well in terms of time, before we go for questions, that there was a very eye-opening incident that took place in one of the families, where we had the mother of the house, and her mother came to stay with her for a while before she passed away. Allah grant her Jannat, inshallah. And the relationship between the mother of the house and her mother became a very daunting one. And I'll just give you one simple example. The mother of the house would make the best food for her. The best food, and she's a very good cook, by the way. The best food. But when that food was given to the mother, to her mother, the mother would react very, very differently. Wat maak jy vir my, en ek wil nie die hê nie, and this, that and the other. 5 minutes later, when the daughter-in-law comes into the house and gives the mother, the old lady, the same food. Mashallah, jy maak baie lekker kos vir my. And this became a very, very daunting situation, But I suppose it's a normal thing. It's a normal reaction, Dr. Parker. But it also highlights to us what caregivers go through in terms of emotional stress and trauma. And the dua which I want to make today is, may Almighty Allah give each and every caregiver the strength to be able to look after these people with this medical condition, inshallah. With that, I also want to mention that we are absolutely overwhelmed. The room next door is completely full. The attendance has been wonderful. We did say that we are going to take some questions, Mohammed. So if there's anybody here and in the room next door that would like to pose a question, and let me say with a lot of respect, we don't want a lecture. We just want a short question. And if the question can be linked to the topic, that would be highly appreciated. If there is anyone, we have a few minutes left before we close, that would like, and don't feel afraid like I was on radio the other day to ask a question which you may think is a stupid question. No question is ever a stupid question, because that same question may bring out so much value to the seminar here today. So don't all put up your hands now, just one by one. Okay, there's a brother at the back.
Assalamu alaikum. Maybe a question to Dr. Ibrahim. You mentioned that one should rather be honest with your context or your situation with the patient around their condition. Can you share maybe just 1 or 2 tips around how best to do that? Because there's this feelings around not wanting to share it and trying to deal with it in a roundabout way. And sometimes getting the feeling that others are saying, but you may be a bit negative. Why are you being so negative on this topic? Rather be positive. So how would the caregiver deal with those 2 things? I mean, doing the actual, communicating to the patient, and secondly, trying to actually show others that this is actually the right way to do it. Shukran.
Shukran.
I think importantly you need to realize first of all the degree of dementia. I don't know if I'm correct in saying that. If it is dementia that is very, very extreme, you are going to have difficulty in convincing that patient that you have dementia, because they are in complete denial, number one, and number two, they might not be of that thought process that they can accept that fact. Okay, so let's just move away from that extreme and rather look at the initial and the mediocre, if I can put it that way, dementia. You need to first of all be very positive with the patient, in the sense that you mustn't look at it as, although it is a debilitating disease, okay? They need to realize that, listen, I have this illness, and I tend to move away from the word disease, and I try to equate it to, if you go and see a medical doctor and you have a problem with your heart, you have a heart problem, what are you going to do about it? Okay? Many a times you get this refusal and say, yeah, but what makes you believe that I have dementia? I'm only getting old and I'm forgetting. Okay? You need to be very, very sure with, if I can put it with proof, that this is what you have, so I'm not sucking it out of my thumb. Okay? But initially I think you sort of just pave your way in the sense that, you know what, I'm here to help you. This is what we have. How can you help me to help you? Okay? Move the problem onto yourself, in the sense that I have a problem. I need to help you. You're not saying you have a problem and I need to see to it. You're not blaming. Okay? So you're being positive. I have a problem and you are going to help me. This is what the situation is. Can we do this together? And here again, I mean, sometimes, because I think it's my passion, I'm going to refer to it as parenting. when you have a problem with the child, you use I messages as opposed to you messages, because you messages is very blaming, whereas I messages is I'm taking responsibility for it, but you are going to help me in remedying the situation. And maybe that's one way in which you can. And I think, like Dr. Parker mentioned, you can't really pigeon box it. You can't just say that is the way. Each one, you need to look at it from a different perspective.
Okay, we have a lady from next door, the microphone.
Assalamu alaikum wa rahmatullahi wa barakatuh. Dr. Parker, I just want to ask the question. There are times when my mom refuses to take the medication because she's frustrated, she's angry, she's sick and tired of taking the medication. So she will take it and she'll throw it on the floor, or she'll tell me, go away, I'm going to take it on my own, you don't need to help me, but I know she's not going to take it. So what do I do in that situation? Because it's very frustrating, because obviously she needs to take the meds and I don't know how to get her to eat it or take it.
Shukran for that question, very important. I think it is, it's very tricky. We have to be very creative when we have patients with advancing dementia. And so as doctors, as geriatricians, we always try to decide what actually we can take away and what they really need. And if it is a medication that actually helps her sleep and helps all of you get good night's sleep, so tomorrow you're fresh for her, you just put it in the yogurt. If it's vitamins or it's like vitamin D or calcium, which is also very hard for them to take because you actually have to swallow it whole, you can't chew it, then we leave that out. She sounds like she's quite advanced, she needs quite a lot of assistance. We need to kind of simplify, what do we need, what don't we need? And of those medications, sometimes you just have to trick them, you have to put it in the yogurt, you have to pop it in their tea, you have to find somebody. It doesn't mean you have to give it right now at 5 o'clock. The doctor said every 5 hours you must get the medication. Sometimes you just have to go with the flow. And when you start realizing you're looking after somebody, you have to work with them how they are on that day. And when it comes to medication, we try to simplify what we need, what we don't need, and then we find creative ways to give it to them. If it's not something that is required to control their blood pressure, to make sure the sugar doesn't spike, then you know what, if today she doesn't take a vitamin D and a calcium, what you're going to do. You need to pick your battles. But if it's essential medication, you can always just put it in the yogurt. Or if you find that there's somebody, say for example your brother or your husband, that she doesn't mind having breakfast with in the morning, and they have a gentler way with her, that she just sits and casually has tea, and they're like, oh, I forgot to take my tablets. Oh, mommy, are yours? Would you like some? Do you want me to get you some water with that? You have to be creative, and that's why it's so exhausting for the caregiver, because the whole day you're just like playing games and you're managing yourself. Okay, I hope that answers the question.
Another question.
Assalamu alaikum. First of all, I want to say thank you to Dr. Parker. I met you in 2018 with my mom-in-law, and I love you. I still make lots of dua for you because you saved me. I was the prime caregiver at that time. She's passed on eventually, but I just wanted to say to all the caregivers here, there is hope, and listen to Dr. Parker. Take the time off. Go and have a cup of coffee with your friend or whatever. It really helps. Firstly, it was to be like, is she going to be okay? I used to have full-time caregivers, but still, I was still the prime caregiver. But you have to take that time off. Eventually, she got bedridden, and it got quite worse. Dementia, everything. She had to have a leg amputated. We were going from pillar to post with the doctors, with hospitals, in and out, and we kept meeting people, or doctors or professionals, to say that we have to, come to terms with passive euthanasia. And that's why I want to ask Dr. Yusuf Patel and Dr. Parker. It was shocking for us as Muslims to accept something like that, because we tried everything. I mean, anything happened, we'd go take her to emergency and try to get it sorted out, and not just say, okay, now we must leave her. So I just want to know, how do we deal with that? I mean, after 3 years, I still have that thing is, how do we deal with this passive euthanasia that's going, that people tell you about? Shukran.
Shukran for that question. Yeah, I think that's a very contentious area in bioethics. I remember I had this discussion with Professor Mohsen Ibrahim a few years ago, who is a specialist in Islamic bioethics. And I think, again, we have different schools of thought. Different Muslims with different persuasions would obviously view this according to how they premise the situation or how they premise the circumstances. But I think the normative position within the Islamic tradition, at least in this current time, is that euthanasia is not something that we allow or that we agree on. I know a couple of years ago there was a talk Mr. Parker, I remember when I was still a medical student, or when I just finished, it was probably around that time, there was a seminar in Ramadan with regards to euthanasia. And then there was a scholar from New Zealand that flew in, if I remember correctly, a non-Muslim, and he obviously was promoting the concept of euthanasia. And again, the arguments are compelling to a certain degree when you actually understand and you see the difficulty that people go through. When we hypothesize and we pontificate about, that Islam says this and we shouldn't do this and that it's equivalent to suicide, we become very emotional and sensitive about it because we're taking it from a religious perspective. But when you're in the actual battle with a family member and you see the suffering and you see the difficulty, you can understand why people want to invoke that option. But I think for our current times and our current practices, at least in the South African setting, as far as I know, I don't think euthanasia, even assisted euthanasia, is legally allowed. So I don't think it's something that we should even, consider. But saying that, this discussion is going on, and I think for the next couple of years, if not longer, you will find new thoughts within the Islamic camp with regards to justification. But the normative position as it is now is that any form of euthanasia within Islam is not accepted.
Thank you. Thank you. Yeah, please.
Sorry, I think maybe, I'm not quite sure that the doctors, and I may be wrong because I wasn't there, meant euthanasia in such a sense. I think they may be talking about palliative care, which is really very different and something that's very important for us to offer to our patients. And as I mentioned, at every stage that we have a patient that is going through pain and suffering, and there really is no alternative for us to offer the patient, that we give them care with dignity and with quality. And I think that may be what the doctors were trying to say, rather than passive euthanasia. I don't think there's such a thing. Yeah, so obviously I think it should be taken patient by patient, and it's really about understanding, if we were to take your mum and do an operation for her, there is a huge chance that she's not going to come out of this. And so would we want to make sure that she would have the time to be with her family and care? We can all recite and care for her, but still doesn't mean don't feed her. It doesn't mean don't, if she's got pain, treat the pain. It's palliative care. It's giving them comfort, it's giving them care, it's making them comfortable, and it's giving them dignity. It's not euthanasia. So I just want to, there is a form of care that we can give with kindness and with respect, and to make sure that we help our patients and our families, navigate this illness to its end. And some patients may never get to that point. Some of our patients pass away in their sleep, and they're very fortunate that way. But there are some families like you have, it's just a roller coaster all of the time. And then you need to come to a decision with what are you comfortable with, what intervention you are in. And there's no right or wrong answer, but you need to be comfortable with that, with that decision that you make in that intervention.
Thank you. We'll take 4 more questions, and then we'll bring the seminar to an end. Mohammed?
Okay, the next one is from the next room. There's a written note and question. My mother had a stroke in June. She is sharp sometimes with her memory, yet she is forgetful. Does a stroke lead to dementia?
Simple answer.
Yes, it can. It's one of the risk factors. But obviously there's much more that goes with that, but yes, simple answer.
Thank you.
Assalamualaikum. I got some of my answers from the previous questions. My mom was 91 3 days ago. She doesn't eat properly. She plays with the food or messing the food, but then I find she eats tissues. She dips it in the tea or whatever she have, and that's one thing. And she's in denial. She's not sick. There's nothing wrong with her. Doesn't sleep. I've been up since 2 o'clock. And walks in the dark, and she fell twice in the past 2 weeks, so I know I have to be up when she's up. So I'm the primary caregiver. I'm the only caregiver. I have one brother left, and she's my responsibility 24/7, 365 days of the year.
Yeah, no, that is really very hard, and we make dua, like Mr. Parker did, that, you know, Allah guides you and helps you in, to manage this burden. I mean, so I think for your mum, it's very important for us to understand why is she not sleeping. You know, is she sleeping during the day? Are you busy working and so she's not being kept busy? You know, so it's important to understand why is the patient not sleeping and try and get that sleep-wake cycle a little bit changed. Keep her up as late as possible. If you need to take her for a walk and make her tired during the day, that's fine. If she can sit up until 2 o'clock and then you can maybe sleep from 2 till, okay, well now it's Fajr, but you know, until that time, you can at least get in 4 hours of sleep. So I think there's a lot of things to try to understand why she's not sleeping. Patients with dementia, they do have a tendency to sleep less. We're not going to get them to bed at 8 o'clock like we did with our son, and then he wakes up 6 o'clock in the morning. It doesn't work like that, you know. They do require less sleep. So I think first is to identify what is it. You know, are there things during the day? Are you giving her caffeine at night? Does she wake up because her bladder's full and she needs to go to the toilet? There's so many things, you know, that could be contributing to why she's not sleeping. And if all of those things are addressed, does she have pain? Sometimes just giving them Panado before they go to bed actually helps them. So 2 Panados, you know, and keeping them up awake as late as possible, not overstimulating them. Can help. And then secondly, with the tissues, it's going to cost you money, so make sure that it's biscuits and take away the tissues from her, you know. So you just have to remove the thing that she's dipping in the tea, so she doesn't know that she's got dementia. It's okay. What is it going to change? She's got you're giving her food, you're looking after her. I mean, her life is grand. It's like our son, you know, he just exists, so she can just I'm sorry, boy. So you know, I think trying to explain to her, like Dr. Ibrahim, Professor Ibrahim said, is that it's really pointless. You know, what is it going to change for you? What is it going to change for her? So if she's dipping the tissues in the tea and it's costing you money, give her biscuits or rusks to dip. You know, but I think it is important for you to get some sleep, because when you yourself don't sleep, you can't manage. You can't actually manage her when she's difficult. So okay, well, there's the problem. You know, that kind of maybe needs to be addressed. We don't really want to give her the Detronorm, but there may be something else, you know, that could be considered. I don't know if you have a GP that you can see, that they can maybe first look at those things to see what is actually triggering her waking, and if there is a possibility to give her something, you know, for that.
If
you as a caregiver, you have to be innovative, okay? Yes, get biscuits, but biscuits might not be as soft as what tissue is, because sometimes they're sensitive to feeling. Make a panakuk. You know what I mean? So look, it takes a lot from a caregiver, because you have to practically think of everything, not for yourself only, but for the patient as well. But you need to be innovative. You need to be one step ahead of them. And basically that's what you need to do.
Can I just mention to you that I've actually seen so many in my life cases of what you're going through. And if I can just offer with respect to the panel some consolation to you, because I've noticed that whenever the caregiver has given, especially when it comes to your parents, that support which you're supposed to give them, and I'm sure you are doing that, when that person has left the dunya, your life changes completely. Your life changes completely. Almighty Allah just elevates everything in your life for you. And may that be the dua for you today.
Amen. Amen.
Secondly, you know, there's a lovely saying that you must go with the flow. You must go, Shanaz, with the flow. Go with the flow. But many times I'll tell people, don't go with the flow. You flow with the go rather. That helps mentally. Okay. Second last question.
Assalamu alaikum. I would just love to pose the question. I see everybody speaks about women, and we know women lives longer, so dementia is probably very popular with women, but also with men. And with regards to the age of men at the onset of dementia, Doctor mentioned earlier on, Dr. Patel, that there's blood tests or cognitive, like I've been to a neurologist, to a neuropsychologist, but I haven't heard about blood tests. So my question is, I know that my kids look with fear, and probably I have the question, is there any genetic, connection or connotation when we speak about dementia as well? If it is in the family, will we also have dementia in the future? And what tests are being done? Because if we speak about breast cancer, we speak about the BRCA test that's being done. So when we speak about dementia, what tests are there to reassure maybe the children?
Excellent question. Excellent question.
There's specific genetic tests mainly for the early onset. So patients who are in families where it's young onset dementia, so before the age of 65, I don't specifically do it to send the patients for the test, but there are specific genes that are involved. And I'm sure if you contact the genetic companies and obviously the institute, so like Professor at Grooteschuur and at Tygerberg, they will routinely do that. So that there are tests, there are specific genes with early onset dementia. It's your presenilin gene 1 and 2 on your specific chromosomes, and you need to have both gene abnormalities in order to carry and possibly infer the risk of having the disease. It doesn't always mean that you will get it, but you could still be a carrier. So there are specific genes, and then obviously in the late onset one, I did mention that if you have a family member who's had Alzheimer's or frontotemporal dementia, you do have that risk that it could happen. Sometimes I think with genetic testing it's very important because they do a lot of counseling with it, because obviously if you have this result and you have a progressive neurodegenerative disease, what are you going to do with that information? Are you now going to live in fear that at the age of 50 I'm going to be in diapers, you know? So there's a lot of important counseling and understanding that goes on before you do these tests, because they are progressive neurodegenerative disorders, and there is no cure for them. But there are risk factors that you can modify.
So I just want to, one more. So with regards to the onset with men and women, are there specific ages? Because what I've noticed or seen was that men has an earlier onset than women.
No, I don't think that there's specific. So it just sometimes in certain patients, if they've worked all their life, and we can often see that with men, when they lose that mundane routine of getting in the car, going to the work, coming home, getting in the car, going to work, coming, when they come home and their wife is busy, she's busy, you know, and she's not sitting with them, she's cleaning the house, she's organizing the grandchildren to be fetched, she's organizing her life. Women have mostly learned how to keep themselves busy, and a lot of men haven't. And so when thank you, ladies. Yeah. So when men retire and they have no outlet, which is something I'm like so proud of my dad for. Everybody's telling him to stop working, but he does drive us insane. He is busy competing with cars and trying to do something. So when you don't have something outside of your routine and your job and you suddenly stop it, then it's the worst. And we're seeing, and I don't know, Professor Hussein, if you are seeing a lot of men who retire who then become depressed because they didn't plan their retirement. It's happened a lot in COVID. I've seen a lot of older men become quite sort of depressed afterwards and then rapidly developing a cognitive decline because that routine, that what they've been used to, is gone. And they've got no purpose because their work was their purpose. So a very important point, your work is not your purpose. So you need to find a purpose. You need to find something outside of yourself that you do for other people and for your loved ones. And you need to find a hobby before you decide to close the doors to the law firm or the doctor's practice or leave the accounting firm. You must put things in place. So you're probably just seeing it because the men in your life only work and you do everything for them.
Spoken like a true Parker. Our final question, Professor Shabir Wadi.
Assalamu alaikum. Question for Dr. Parker. Before that, I must commend the organizers and the speakers for an excellent panel. And as I asked you, I hope you're recording this for the benefit of those that are not here. My question is a simple one. Dr. Parker, you alluded to or you referred to certain factors. My question is, are there any environmental factors, physical factors, or dietary factors that can accelerate dementia? Maybe, I mean, it's very hard to say dementia, but so many different forms.
Yeah.
Are there any known ones?
So, I mean, air pollution, and really I haven't gone, it's just a random thing in countries where we see that there's a lot of sort of waste and, toxins in the air, that increases your risk, and that's really in later life. So when you talk about diet, like I mentioned earlier, the Mediterranean diet is being punted everywhere for good reason, because it has been shown to be beneficial on cardiovascular risk. And if you saw my talk before, good heart health is equal to good brain health. So it improves your cholesterol, your blood pressure, all of that. So mostly with regards to diet, there's no specific food, there's no specific supplement that will reduce your risk. Your risk you need to manage, and if you do have high cholesterol, hypertension, diabetes, you need to make sure that is controlled. And physical inactivity is a risk for developing dementia. I showed it earlier. I think there's a 3% chance if you are inactive that you have a risk of developing dementia. Over and above, should you have a family member that has dementia. Over and above, if you don't wear your hearing aids. So I hope that answers your question, Professor Wadi.
Okay, ladies and gentlemen, that brings us to the end of the seminar. But before you go, on your behalf, let us thank Dr. Fahima Parker, Dr. Yusuf Patel, and Dr. Hussein Ibrahim, a formidable team that we've had here today. And I think, I speak for myself, I've been empowered, and I hope that you have also been. If you have, please give them a very, very warm round of applause. May Almighty Allah bless all of you, inshallah. As a Muslim community, we're very proud of all of you, especially a Parker. That's by the way. The event has been recorded, and it will be uploaded on YouTube, inshallah, by tomorrow. And you can just spread the word around. I also want to thank Anwar Rumani. Anwar, just come here. No, come here. He's one of the people in the background doing all the recording here today. Give him a warm round of applause. Siraj Parker, our technical man, and the rest of the amazing committee at Masjid al-Quds, headed by Muhammad Abdullah. Give them also a very warm round of applause. There will be a parenting workshop. It's titled Parenting in Challenging Times. It will be done by Dr. Hussein Ibrahim. That's next week on, not next week. 24th. 22nd. Spread that word around. Difficult times. We have to, Hazrat Ali has said very beautifully, rear every generation different to the way you have been reared. Beautiful words, very profound words. And today, you can't tell a child to keep quiet and sit down and shut up. Those days are gone. Those days are gone. Those were our days. Those days are. Here is the man. He's going to take you through that journey. So spread the word around. And on behalf of everyone here, let us wish you all the best for the remaining days of Ramadan, inshallah. And may Almighty Allah grant every wish and desire that you have. And may all the caregivers be given a special place one day in the year after, inshallah. Shukran so much. Assalamu alaikum wa rahmatullahi wa barakatuh.